By the way, look at me instead of me.
Sure.
Hello, and welcome to another edition of Health Matters, brought to you by WCCA-TV and the Worcester District Medical Society. I'm Dr. Bruce Karlin, your host for another edition, and it's my pleasure to have the Chief of Urology at St. Vincent Hospital, Dr. Chintan Patel. Welcome.
Thank you so much for having me, Dr. Karlin.
Well, I'm delighted that you're here. In full disclosure, I would have to say that your group has taken care of me in the past, but there are a lot of good urology groups here in the city. It's a very rich community. But welcome aboard, and thank you for talking to us.
Sure.
So when we talked about what we were going to talk about, you have so many topics in urology. All of us are aging, so our prostates are going bad.
Sure.
Our erections aren't what they used to be. We're incontinent, and you address all of these problems in urology.
That's correct, yeah, and I think those are some of the most common problems that we see and we try to help our patients with. I think first and foremost for our men are issues with the prostate. And as men age, there's two big pathologies, problems that affect the prostate. One of them is obviously prostate cancer, which I think we all know at least one or two people in our circles that have had this diagnosis. And the other problem that affects the prostate is it causing troubles with urination for men. And that's more of a quality of life issue, not so much a cancer issue.
And by far much more common.
Way more common, correct.
And indeed, much of what we tell our primary patients is that most of us that get prostate cancer are going to die with it rather than from it.
Yeah, no, I think that's a lot of prostate cancer is low grade. It is what I tell my patients, it's really well-behaved prostate cancer, and it's quite indolent. Where we do a treatment modality for, again, low-risk prostate cancer called active surveillance. And the way that I tell our patients is we just keep a super-duper close eye on this cancer. We just make sure it doesn't change its colors, and if it decides to change its colors, we change our treatment plan.
The old issue that was fascinating was when they did biopsies on the soldiers that had died in Korea. They noted that a lot of them had cells that looked like cancer.
That's right. Yeah. No, I think, and
we're talking 20-year-olds.
Right. I think the paradigm has shifted dramatically since the late 1990s, early 2000s, where we are watching a lot of men with active surveillance and not doing any aggressive life-altering treatments.
So that gets into the constant back and forth between urology and primary care of how best to survey.
This is a topic that's close, near and dear to my heart, and I definitely hear the perspective from primary care doctors where PSAs are not a great screening tool. You can have false positives, and it makes it difficult to kind of explain to patients what this test really means. And what I tell my primary care doctors when they ask about this is, I think the first step is just to have a conversation with the patient, right? Discuss that a PSA is not the only data point that will assess your risk. We look at least 7 different things in my mind. We look at kind of the total PSA. We look at the PSA velocity. Has it changed year to year? There's an adjunct test within the PSA called a percent-free PSA, which is important. Family history. If your dad or your brother has had prostate cancer, you're 2x the risk of having it as well. African Americans are at a higher risk of having prostate cancer. So, my response to, primary care doctors and patients is it's not just one lab. It's really like 6 or 7 different things, and urologists look at all 6 or 7 of them.
Well, and also you're taking a less aggressive, less instrumented aggression in this, and you're watching the way so that those false positives don't come up to bite you as the way they used to.
I couldn't agree more. Generally speaking, there's always exceptions, but when a man between 55 and 75 comes to me with an elevated PSA, plus or minus family history, or an abnormal, prostate exam that an astute primary care doctor did, I'm not going directly to a biopsy. Very few urologists are going straight to biopsy. We're ordering an MRI beforehand. And if the MRI comes back totally clean, we're trying to avoid as many biopsies as possible, and we're only trying to biopsy patients that have a remarkable finding on the MRI.
So when it comes to counseling patients, it's that discussion and understanding. The patient can take some risk by not doing it, but he also takes some risk by doing a PSA.
Correct.
And so they've got to make their own decision, and we've got a good place to turn.
Absolutely, and the same thing with primary care doctors. I think I say this proudly is like we are actively trying to avoid biopsies, and we have more tools in our kind of toy chest from when we did 15 years ago when everybody was getting biopsies. Now, again, we're trying to avoid, and if there's a data point that says, the patient doesn't need a biopsy, we are trying to avoid it.
Talking about toys in your tool chest.
Yes.
Let's talk a little bit about what I should do with my patients that are complaining that the prostate's getting in the way of their normal peeing.
Right. So let's say that the prostate cancer evaluation has been complete, and there's very low risk of that, but the men are complaining of a slow urinary stream, needing to push to kind of get the urine out, dribbling after peeing, kind of drip, 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 and sometimes the bladder not starting the process of urination for 30, 40, bingo, exactly. Those are all what we call lower urinary tract symptoms, and that's just the terminology used for a prostate that's obstructing the flow.
They should understand this is not prostate cancer.
Correct.
This is quite different. This is just normal aging of the prostate. It's growing.
That's right. It's a mechanical obstruction, and unfortunately, this is something that generally gets worse as the years go on. And there are good medications that that have been around for quite some time, and we generally try to reach for medications first as a first line treatment, and then we have, like you mentioned, other procedures.
From the primary care perspective, I find that the medications help a little. They're not, and it's a disease that I think of as it's a disease that when you cry uncle is when you go to the urologist.
I think one of my engineers or one of my patients described this. They said, well, Dr. Patel, what you're describing to me with this BPH, it seems like it's a mechanical problem. Why are you giving me a chemical solution for a mechanical problem? And that sort of resonated with me, and it makes a lot of sense that if that urethra is blocked by an obstructive prostate, might as well at least consider some procedures to open up that channel.
Well, part of the reluctance is that the older procedures were, let's say, far more ham-handed. They were not I can remember some of the early procedures, you had terrible bleeding, and
Yes.
then somebody came up with a way of clipping the artery so that you could see what you're doing. But it was still really like a bull in a china shop.
Yeah, I think the old term of one of the most common procedures that we used to, that we still do, but it was called a roto-rooter, and that's just the common way of describing a TURP, a transurethral resection of prostate. And yeah, it did come with some negative consequences. Ejaculatory dysfunction, and it definitely had an influence on the quality of life of a lot of men. And as the technology has evolved, the side effect profile of the newer procedures is in my opinion, much lower than what it used to be.
Well, and certainly from the primary care point of view, we're seeing people are delighted with the new procedure. Perhaps you could describe the new procedure. It really is a step up in technology.
Are you referring to the aquablation?
The aquablation.
Yeah, that's that's one of 6 or 7 different modes of therapy that we offer. But aquablation is what I call the new kid on the block, and it uses a high velocity water jet to open up that channel. It's the same technology, it sounds a little crazy, that is used to cut diamonds. It's the same technology that's used to cut slabs of concrete. It's just water at extremely high speeds. And what the beauty of this procedure is that during the actual procedure, I map out every millimeter, every inch of that man's prostate. Where does it start? Where does it end? Where's the
roof?
Where's the roof? Where's the base? Where are the ejaculatory structures? I try to protect that if that's a priority. And once I have that 3D configuration of that man's prostate in real time, I hit the button start, and then the robot that controls the water jet ablates exactly where I direct it to.
So the technology has created a much better map of what you're doing.
Yes.
And then actually gets
and the execution is better. It's like both of those worlds have kind of come together.
It's not like we're guessing where we're going.
No, there's very, very little guesswork now, and
but you have to have a certain size before the aquablation works.
Yes, I'm a big fan of kind of collecting all the data points before we pick any procedure. I like to know the size of the prostate, and I like to also look at the inner anatomy before we sign up for aquablation. And there are other procedures as well.
So why don't you describe a few of those?
Yeah. So there's a smaller procedure for there's a procedure for smaller prostates known as a urolift. That's a quick 5-10 minute procedure. For larger prostates, there is a procedure called a HOLEP, home enucleation laser of the prostate. I personally don't offer that procedure, but if I have a man who needs that, I have friends in Boston where I did all my training that I can send them to have that procedure done. There's a robotic simple prostatectomy. Like I said, there's 6 or 7 good options.
And all these technologies are dependent on better mapping of the prostate before you go in.
Bingo.
It was in the old days, you sort of
Everybody
felt thing with the catheter, and that's about where it is.
And it was one size fits all because there wasn't that many different options. And now even the interventional radiologists do a procedure called prostatic artery embolization, where they kind of cut the blood supply to the prostate, and the data for that procedure, which is super minimally invasive, is promising as well. So there's a lot.
So in other words, if you're dribbling, if you're having trouble initiating, if you're having leaving a little in the pants, if you're and you say uncle, it's about time that these procedures are far better than
Correct.
what they were even 5 years ago.
100% agree with that.
And So what should we be telling patients? You know, this is really as you were saying, quality of life issue.
Correct.
And when it bothers you enough that you can't initiate, do you have cutoffs that work for the symptoms?
I think I have a lot of binary questions, you know, and I think primary care doctors should ask the same. If, let's say, you had a patient who was having peeing troubles and you gave him Flomax, when you see him in follow-up, hey, are you happy or not happy, right? And if the answer is not happy, then we need to figure out,
Make you happier.
Bingo, exactly.
At that point, a lot of my patients say, well, I'll just live with it. And that's fine.
So
All right.
here's my only caveat.
You're gonna
I think about the bladder
yeah.
as a muscle.
Uh-huh.
It is a muscle, but it is a muscle that you do not want to overwork.
Okay.
Do not want to overstress, like the heart is a muscle. Because over time, that detrusor muscle, if you are overworking it, it will stop working. It will work way less efficiently. And at some point, that patient may become catheter dependent, and the window to intervene was 10 years ago or 15 years ago.
All right. I've lived with it a long time. I might be calling you. It's an interesting way of doing it. Maybe your data is such that you're having far fewer
Yes.
problems with post-prostatectomy, incontinence, and the other issues that we used to have with that.
Yeah, no, the incontinence rate after bladder outlet procedures for helping men pee better are, virtually zero. But as you referenced, if a man has had a prostatectomy for prostate cancer, those incontinence rates are there. But again, that's a completely different beast.
Well, that's a different kettle of fish,
Yes,
too.
absolutely.
And that's a much smaller population.
Yes.
So part of the issue is in the primary care world, we see a lot of people that mix up prostate cancer with prostatitis or
BPH.
benign prostatic hypertrophy,
Correct.
which is just big prostates. If you live long enough, you're going to have a big prostate.
Or one of the two, right? Yeah.
And it's important to know, there's certainly a message I would get from this, strongly consider a PSA.
Oh, yeah.
And strongly consider corrective surgery if you're having significant prostate.
I definitely
symptoms.
wouldn't wait, and then ultimately at least establish care. And then, I or one of my partners can follow you, and then we can keep track of you over the next 2, 3, 5 years. And it's always a group, it's a team decision before we move forward with any procedure.
Yeah, no, as Woody Allen would say, it's my. He talked about his brain. He says that's my second favorite organ. But, the other issue that we wanted to talk about, and I don't want to shortchange it, is incontinence and female incontinence as well.
Yeah, I think that's a big part of my practice, and it's a problem that I enjoy working on because it can be such a detriment to quality of life. And when it comes to female incontinence, there are two. I kind of split it into two different pathways. One is urgency incontinence, where the ladies say that I just can't make it to the bathroom fast enough. And it's urgency, frequency, and again, God forbid that bathroom is locked when you got to go, and then you're doing like the pee-pee dance. And we have such amazing lines of therapy for urgency continence. It could be medications, and obviously lifestyle modifications, limiting coffee, tea, all that kind of stuff. But most people have already done that before they come to see us. So second line therapy are medications, which there's lots of them,
and some of them are quite effective.
They are effective. And again, my goal is the happiness of the patient. If I give them a pill and 3 months later they say, hey doc, I have so much,
cured, yeah.
I'm good, right?
Except that it's just like with the prostate. It's not cured. It's
managed.
delayed.
Yes.
It's delayed.
And then third line therapy for urgency is I do a lot of intravesical Botox therapy, and I tell you that really works like magic, and it has changed lives where I get calls from really happy patients a week after I do the procedure saying, Dr. Patel, I threw away all my diapers. I'm booking a trip to Europe because I feel like I have control back in my life.
How long does the Botox, intravesicular Botox work?
Great question. It's all bladder dependent. I have some ladies where once a year we do a quick 2-minute injection in the office, some every 9 months, some every 6 months, and I have some neurogenic bladder patients that are so advanced that they come every 3 months. But
But it's on the order of months, not weeks,
correct.
not days.
Exactly. And then the other, the toy in the tool chest is sacral stimulation. And we do, I like to describe it as like a bladder pacemaker, where the connection between the bladder and the brain is off. And this implant kind of makes
Reestablishes
them.
it.
Exactly.
Just getting back to the Botox injections, as with other Botox injections, there's always the issue of got a little too much in there, or some of it got in the wrong place.
Excellent point.
Have you had any problems with that?
There's a 5% chance that the Botox works too well, and the patient may need a catheter temporarily just until the bladder wakes up again. It's rare, but again, I think most of the patients who sign up for this procedure are so miserable from a leakage perspective that they'll say, I'll take my chances.
I would just also put a caveat that from a primary care perspective, I often will send incontinence patients to a gynecologist first to make sure that there's not a uterine problem.
Prolapse, yes.
That's just changing the architecture enough to make
Sure.
the prolapse happen.
Sure, yeah, no.
But and getting back to the symptom, we're often going the difference between urgent continence and just stress incontinence.
Exactly, and that's the other path. And stress incontinence is very black and white. It's the leakage that happens with coughing, sneezing, jumping, working out. And that's a completely different ball of wax, and there's a different treatment pathway for stress incontinence. And there's a newer procedure that we've started doing over the last year called Bulkamed that takes about 5 minutes to do, and we inject a hydrogel to the urethra. I describe the urethra as like the stopcock, the tire that's supposed to hold the urine in. And after giving birth, after carrying, a child in your belly over,
Blame your kids. Yeah.
Exactly.
Obviously.
That tire has kind of lost a little bit of air, and putting this super duper water-based gel directly into the urethra kind of bulks up that tire, and the results.
It's a principle all across surgery. We do the same for larynx, for vocal cord problems, and other places where you've got a sphincter that's got to close. You just give it a little boost to give the little margin it has a little bit more margin.
There you go. And then, like you already referenced, we rely a lot on our urogynecology colleagues. If there's a problem that I can't fix, I always phone a friend as well, and they're very, very well versed in all of these techniques as well.
What's amazing to me is how much less in-hospital surgery you're doing. All this stuff is in the office, isn't it?
Or the surgical center. Yeah. So a lot of what the Botox happens in the office. A lot of the trials for the stimulation happen in the office. And like I said, the Bulkamed procedure for stress urinary incontinence, it happens at our surgical center. And again, it's a quick 5-minute procedure.
Huh. There are some things that people confuse, and just from a primary care perspective, I see people say, well, I wake up to pee, and in fact, they're waking up and peeing, and it's important to make that distinction because the people that wake up and pee probably have obstructive sleep apnea or stuff like that. And so they might get to you and they say, hey, everything's fine. But just put that in the back of your mind. If that is your sole urinary symptom, you might want to check with a sleep specialist.
Absolutely. In our conversation to this point, the one symptom that I didn't really talk about is waking up at nighttime, because there could be few other reasons for why that could be. It could be the fact that you're taking 8 pills at 9 p.m. with a large glass of water. It could be because of obstructive sleep apnea.
Well, certainly from the primary care point of view, we see it far more often that it's a sleep problem than a urinary problem.
Yeah.
If that's your only symptom. If you're dribbling,
Right.
if
No,
the other stuff, you better see Dr. Patel.
Yeah, I think the first thing that I like to distinguish is, does this happen at nighttime or daytime? If your days are perfect and it's just a nighttime thing, then there might be something else going on.
I think we're coming to the end here, if I'm not mistaken. And I would hope that you can just give us a quick synopsis of the big points we should take home.
Yeah, I think the big things are, don't ignore your symptoms, especially if it's not being able to pee or peeing too much or leaking, and then have a discussion with your primary care physician on prostate cancer screening. I think those would be the big takeaways. And then again, the technology has evolved so much over the last 5-10 years that some of the procedures that we offer come with very little downside and really little downtime as well.
That sounds pretty terrific. Well, this has been another edition of Health Matters. I'm Dr. Bruce Karlin, and my guest has been Dr. Chintan Patel. And this is an amazing tour de force of all of urology in a half an hour. And again, I'd like to thank you for being here.
Thank you for having me, Dr. Karlin.
We'll sign off now. Thank you for watching Health Matters, brought to you by WCCA TV and the Worcester District Medical Society. I'm Dr. Bruce Karlin. Thank you for being here.